Today, I will be discussing the potential use of ketamine paired with therapy in the treatment of alcohol use disorder. This study, titled Adjunctive Ketamine with Relapse Prevention-Based Psychological Therapy in the Treatment of Alcohol Use Disorder, was published in February 2022 in the peer-reviewed American Journal of Psychiatry, which has an impact factor of 18.11. So some background. Harmful use of alcohol causes more than 5% of the disease burden worldwide, and a great proportion of individuals with alcohol use disorder do not respond to currently available pharmacological and behavioral treatments, with more than 70% of those entering treatment relapsing within a year. However, early evidence suggests that ketamine may be an effective treatment to sustain abstinence from alcohol. So this study was conducted to test whether ketamine may be an effective treatment to sustain abstinence from alcohol. The authors investigated both the safety and efficacy of ketamine compared with the placebo in increasing abstinence in patients with alcohol use disorder. An additional aim was to pilot ketamine combined with mindfulness-based relapse prevention therapy compared with ketamine and alcohol education as the therapy control. So the method. This study conducted was a double-blind, placebo-controlled phase 2 clinical trial. There were 96 participants in this study, all of whom had severe alcohol use disorder, and they were randomly assigned to one of the ketamine infusion groups or the saline infusion groups. So the results. The treatment was well tolerated and no serious adverse effects were associated with ketamine in this experiment. It was found that there were a significantly greater number of days abstinent from alcohol in the ketamine group when compared with the placebo group at the 6-month follow-up. So, what is alcohol use disorder? Alcohol use disorder, or AUD for short, is a medical condition characterized by an impaired ability to stop or control alcohol use despite adverse social, occupational, or health consequences. According to the NIH, in 2019, 14.1 million adults had AUD, and an estimated 414,000 adolescents had AUD. To determine whether an individual has AUD, they must have the presence of at least 2 of 11 symptoms, which includes questions like, in the past year, have you had times when you ended up drinking more or longer than you intended? Wanted a drink so badly you couldn't think of anything else? Continued to drink even though it was causing trouble with your family or friends? The presence of 2 to 3 of those symptoms is defined as mild AUD. The presence of 4 to 5 symptoms is defined as moderate, and the presence of 6 or more symptoms is defined as severe. So why ketamine? While substantial evidence supports the antidepressant properties of subanesthetic doses of ketamine, which led to the FDA's approval of esketamine for use in treatment-resistant depression. Depressive symptoms are common in individuals entering treatment for AUD, and the likelihood of alcohol relapse is elevated in patients with such symptoms. Ketamine may support alcohol abstinence by temporarily alleviating depressive symptoms during the high-risk relapse period in the weeks after detoxification. Also, several studies have directly investigated the effect of ketamine on patients with problematic alcohol use. Some of those studies have shown an increased abstinence rate after receiving ketamine infusions. So, ketamine could be a promising candidate for helping treat alcohol use disorder. This was a double-blind, placebo-controlled phase 2 clinical trial. A phase 2 clinical trial means that researchers are testing a small number of patients to assess safety and gather initial data on efficacy, which is what this trial did. Given that very early evidence has shown it might aid psychological therapy and might be a beneficial treatment for AUD, this study was conducted to investigate the safety and feasibility of ketamine infusions compared with saline infusions, the control, in increasing abstinence in patients with AUD. So participants. Participants were recruited from the community through social media and newspaper and radio advertisements, as well as from primary care and secondary drug and alcohol services. all participants had to be abstinent for at least 24 hours, as well as have the goal of abstinence for at least the 6 months of the trial. Current level of alcohol use was assessed during an initial telephone screening. Alcohol abstinent individuals were invited to a screening visit. After the screening visit, eligibility was determined based on the patient's medical history, physical examination, mental health assessments, blood and urine analysis, and a breath alcohol test. Eligible participants had to be 18 to 65 years old, meet DSM-5 criteria for moderate to severe AUD, have a good command of the English language, be currently abstinent from alcohol, and have a negative urine screen for all drugs apart from cannabis and benzodiazepines. Exclusion criteria included the use of antidepressants, current suicidal ideation, a diagnosis of substance dependence, except for alcohol use disorder, and a history of harmful ketamine use. So the study design, participants were randomized to one of 4 treatment groups: ketamine and therapy, ketamine and alcohol education, saline and therapy, and saline and alcohol education. Participants were invited to attend 10 study visits. The therapy versus alcohol education. From visits 2 to 8, participants received either manualized therapy or alcohol education as a placebo control for therapy. These sessions lasted for 1.5 hours. The aim of the therapy sessions, based on manualized mindful-based relapse prevention, was to support the participants in developing an enjoyable and meaningful life without alcohol. Each session contained one topic related to each of the 2 overarching themes of therapy: relapse prevention and the promotion of well-being. For alcohol education, the focus was on educational topics, including the driving forces of addiction, the biological effects of alcohol, and ways to improve healthy living and nutrition. In contrast to the psychological therapy, these sessions had no formal psychological components. For the drug administration, both ketamine and saline, the placebo, were administered as intravenous infusions. The intravenous route was used because it is considered the best method to control ketamine blood levels and is associated with fewer adverse effects, such as nausea, than intramuscular injection. So how is it measured? A secure continuous remote alcohol monitor, or SCRAM, bracelet for alcohol continuous monitoring was attached before randomization at visit 1 or 2, and it was removed at visit 8, which was the end of treatment. Self-reported percentage days abstinent, as well as drinking events or alcohol relapse, were reported using the alcohol timeline follow-back self-report questionnaire. So the hypothesis was that ketamine plus therapy would be the most effective in sustaining abstinence, and the lowest abstinence rates would be in the placebo plus education group. So, the results. When comparing the 2 ketamine groups, ketamine and therapy versus ketamine and education, the results were not significant for percentage days abstinent or odds of relapse. However, when comparing the ketamine plus therapy condition to the saline plus education condition, the results favored the ketamine plus therapy condition on percentage days abstinence, though there was no significant difference for odds of relapse. So this study demonstrated that treatment with 3 infusions of ketamine was well tolerated in patients with AUD and was associated with more days of abstinence from alcohol at the 6-month follow-up. What does this mean? The findings suggest a possible beneficial effect of adding psychological therapy alongside ketamine treatment. So limitations. Future studies should use an active placebo rather than saline to better maintain the blind. This is because around a third of the patients in the placebo group, those who received the saline, believed they had been given the active drug, whereas nearly all the patients in the ketamine group thought they had been given the active drug, which could have an impact on their self-perceived efficacy in alcohol use. Also, ketamine rates are high in the UK, where this study was conducted. Because rates will likely be higher in a group with AUD, excluding individuals with any prior ketamine experience may become increasingly problematic if this is to be a widely adopted treatment. Future directions. Dose ranging studies have not been conducted, but it is important to establish the minimum effective dose, as ketamine treatment studies in AUD have generally opted for higher doses than those used in treatment resistant depression. So, future studies should consider conducting dose ranging studies given the absence of such a study in alcohol use disorder. This present study adds to the literature done on ketamine and alcohol use disorder by demonstrating that repeated doses of ketamine are safe and effective in prolonging abstinence from alcohol in people with severe AUD who had stopped drinking prior to treatment. And this trial demonstrated that abstinence may be further enhanced when ketamine treatment is combined with therapy. So, while the sample size was small, the data suggests a possible beneficial effect of combining ketamine and psychological therapy that warrants further investigation through future trials. Thank you for watching.